I would invite Dr. Muhammad Waseem from Jinnah Hospital, Lahore for his case. Thank you.
Assalamu alaikum. I'm Dr. Muhammad Waseem, postgraduate resident at Jinnah Hospital, Lahore. Today my topic is interventional management of trifurcating left main stem stenosis. A 50-year-old diabetic male treated as NSTEMI and coronary angiogram was done at another center. He had normal renal function test and EF was 50% on echocardiogram. These are the angiographic pictures showing moderate to severe disease in left main stem. He also had a moderate lesion in distal RCA. So patient was offered cabbage, but he refused. So we decided PCI of the infarct-related artery, and that was diagonal, done in early November. And we advised stress thallium for left main stem lesion significance. Patient lost follow-up and again presented with severe unstable angina in August 2021. Angiogram was repeated. These are the angiographic pictures showing moderate to severe distal left main stem stenosis and severe osteoproximal LA disease. Patient previously placed stent in the diagonal, and there was an eccentric lesion of distal left main stem. There was a sluggish flow in RCA, and this was main culprit lesion in this case. Patient was again advised surgical consultation, but again he was not willing for cabbage. So we decided to further angioplasty of the RCA, and a promised premier stent of 2.75 into 32 mm was placed in distal RCA to PLV. Stent inflated at 14 atm. These are the final results after post dilation with 3.25 into 15 mm NC balloon. Here we take 7 French EBU 3.5 guiding catheter, and IVUS was done. IVUS showed MLA of 4.3 mm square. So it was significant. These are the interventional approaches to left main trifurcations. First is provisional single stent approach, DK crush, call out, and tap. The provisional single stent strategy was selected in this case. A promised premier stent of 2.75 into 38 mm was placed and inflated at 14 atm. Another stent of 3.5 into 38 mm was taken and placed in left main stem to LAD, covering the distal LAD stent. These are the allocranial 2020 view.
Can tech support please help him?
It's quite a sizable circumflex and definitely diffuse disease in LAD. And I exactly don't know what was the age of the patient or how were the rest of the clinical parameters, because definitely single stent strategy is a safer strategy, and without if it's done in a proper way. But left main is a very important vessel. I think we should consider all main branches important, and I would go for but the diagonal branch which had a osteal stenting as well. We should consider that as well. But definitely the person who is doing it, it's in a hot seat actually, so they can decide it better. But it's we must respect the circumflex as well in this particular case.
Go ahead, Dr. Waseem.
One comment, short comment regarding this selection of the strategy. I think left main IVUS and IVUS of left main to LAD was done, but why not doing IVUS of the left main to stroke as well? You know, that might give a lot of information about the amount of plaque burden at the left circumflex ostium and the chances of, worsening of that disease if you go with a single stent. Okay. Angiographically, if I had not done or not opened the IVUS in this case, so I would also go with the same strategy, probably safety wire in the circ and left main to LAD PCI Plus minus, I would also favor doing some lesion modification of the osteal LAD because it looked like a bit fibrotic or maybe calcified as well. So I would have done cutting balloon or something before going for left main to LAD. But if you already opened the IVUS, so why not doing it at the circosteum as well?
Let's complete your case, please.
I'm Dr. Ahmed Mukita. I'm Assistant Professor of Cardiology at Jinnah Hospital, Lahore. I was supervising this case with Waseem. And very good comment by Dr. Anjum that IVUS was opened and IVUS could have been done towards the circumflex, but we did not do it in this case. We did IVUS guided left main to LAD stenting, and final result should have been shown over there, but due to some technical problem, it was not shown. But the final result was good, and final IVUS MLA of 8 was achieved with good apposition of the stents. And we did final kissing balloon inflation without stent in circumflex and left main to LAD, and final port was carried out, but final result, I don't know what's the technical problem over there.
So basically the issue is that a trifurcating left main should be treated just like a bifurcating left main. Is that your point here?
Yes, we did provisionally, and all the 3 branches were saved, including ramus intermedius, including circumflex, and with good result in this case. The question that we wanted to discuss over here, that is provisional approach a good option in this case, and it demonstrated that provisionally it can be achieved with a good result. Obviously, the results of decay crush or other crush techniques or upfront to stent strategies are better.
Was RCA done in this case or not? The PCI to PD or PLV or distal RCA?
Yes, it was done before doing the left main. Excellent. And he showed it before.
Good.
Thank you, Dr. Waseem. Ali Fareh from AFIC would be presenting about a challenging tower case.
None. Have we done jail side branch balloon technique yet? Have we presented that in the?
No.
Because that would have been a useful thing in this case. What do you think?
While this is getting ready, what I would say is the same thing. The question asked in the end was, is provisional 1 stent versus 2 stent strategy? The same principle applies. Size of the side branch, osteal disease, angulation. These 3 things have to be taken into consideration. It doesn't matter if it's a left main LAD circ bifurcation or if it's an LAD diagonal bifurcation. These are the things that need to be considered. And what you are comfortable with, that is also an important thing. You can't start doing something that you haven't done before or assisted before multiple times in a distal left main bifurcation. If you're not comfortable with Q-Lot and you're comfortable with DK crush, you go ahead and do a DK crush. Don't start playing with the Q-Lot stent or whatever the technique that you are not done before multiple times.
Just one comment. For the fellows. Before you embarking on 2 stent or single stent strategy, you must know the definite criteria. And it is different for LMS and for non-LMS. So if your definite criteria is in favor of 2 stent strategy, go for that. If it is not for that and some other condition as well, then the provisional is the best and the default strategy for every case.
की कोई अहमियत नहीं होती. I think we should not keep that in mind कि provisional हम करें. This was complex left main bifurcation. तो उसमें से फिर कुछ और ही option करना चाहिए था. You must have made a different strategy. Kept in mind, try किया आप लोगों ने provisional को. It came out well. That's
Absolutely fine. Correct that left main is left main, so we should respect left main, although it's a vessel like other vessels, but definitely left main should not be treated like proximal LAD one. So a proper plan, proper equipment, number of stents, everything should be planned and executed in a professional way.